Hello, my name is Professor Graham Jackson. I'm a consultant haematologist at Newcastle upon Tyne's Hospital Trust and a professor of haematology at Newcastle University in the northeast of England. The topic I'm going to be talking about today is the question, should all myeloma patients who've had a stem cell transplant receive maintenance therapy? Now, this has been a key question in myeloma treatment over the last 10 to 15 years, and I strongly believe that the answer is yes. Why do I believe the answer is yes? Well, we have a lot of evidence now that maintenance impacts on patients' progression-free survival and overall survival. There's been an interest in maintenance since we had steroids, thalidomide and interferon, and all these drugs have fallen by the wayside as maintenance therapies, either because they weren't particularly active or they were associated with significant side effects. But Revlimid or lenalidomide has proven to be a very important option in maintenance. We've had the CalGB study and the IFM study, and latterly Phil McCarthy has produced a meta-analysis, and we in the UK have produced the Myeloma 11 trial. So we now have 4 large phase 3 studies and a meta-analysis, and taken all together, these studies show that Revlimid maintenance, as opposed to placebo or no maintenance, significantly improved progression-free survival by around about 2 years. But crucially, Revlimid maintenance does not impact on progression-free survival too, and seems to improve overall survival, again in the meta-analysis, by 2.5 years. And that's certainly data that we recapitulated in the Myeloma 11 study. We also know from the CONNECT database in the United States that Revlimid maintenance is associated with similar impact in the community outside of clinical trials. And there's data coming through from Canada, which also suggests that Revlimid in the population, in population-based studies, also has a similar impact on the outcomes of treatment. So overall, we know Revlimid maintenance improves progression-free survival and overall survival. There are several questions still to ask, of course. What is the optimal duration of Revlimid maintenance therapy? We've had data from Myeloma 11 and the Stamina study suggesting that longer-term maintenance is better than stopping after a fixed duration of therapy. We know that is also true from the German Revlimid maintenance study. What about other agents? Well, key is the HOVON study, which showed that Velcade maintenance following Velcade induction therapy significantly improves the outcome for patients with 17p deletion. And so there is a feeling amongst the myeloma community that for high-risk patients after a stem cell transplant, proteasome inhibition, and particularly Velcade, is important. There is some data to suggest that Revlimid maintenance may also help high-risk patients, but obviously it does not completely overcome the adverse impact of high-risk cytogenetics. Lastly, we have the tourmaline study. This looked at ixazomib maintenance after stem cell transplantation, and this study showed an important improvement in progression-free survival of around about 5.5 months for patients receiving 2 years of ixazomib maintenance after a stem cell transplant. This study was really fixed duration proteasome therapy. We also have the Cassiopeia study, which is using daratumumab maintenance after stem cell transplant, and we know that daratumumab induction culminating in a transplant with daratumumab maintenance is having a significant impact on progression-free survival for patients in that arm of the study. So I do believe maintenance is important for all patients post-stem cell transplant, but I do believe we still have some important questions to ask. How long? What is the best agent? Is it important to use an IMiD and a proteasome inhibitor? What is going to be the impact of daratumumab maintenance? And is there a point, if patients are MRD negative, that we can stop treatment? And of course, we have to be aware that all maintenance therapies are associated with adverse events, and we have to manage those carefully so that we don't impact on the quality of life of our patients whilst trying to improve their progression-free and overall survival.